Welcome to this Royal College of GPs webinar. It's on QOF QI and it's called Implementation of the Early Cancer Diagnosis QI module. So we know that you're likely to already be familiar with the recent QOF changes. Now, these give new opportunities for practices engaging in their own population-focused quality improvement, and they build on the prescribing safety and the end-of-life care modules from 2 years ago. So this is the fourth of a series of 4 webinars created to help you get the most out of the quality improvement domains in this year's QOF. Videos of all webinars will be available on the RCGP YouTube channel after this webinar. And what can you expect to take away from this session? Well, a few things. We want to familiarise you with QOF QI in general and include information on the 2021-2022 modules, these ones, and particularly what practices and PCNs need to do. We want to provide a better understanding of the content of this module, the importance of cancer, and a range of options how to approach it. And that's going to be supported by a variety of worked examples. And also, we hope you'll walk away knowing exactly where to look to find resources, and they'll support you and your practices and your PCNs when you plan and carry out this quality improvement work, and specifically where to look for resources relating to cancer. So before introducing our esteemed panel, I briefly want to cover some housekeeping. We'd like to make the video recording of this webinar available to people who are unable to attend tonight. So we're going to focus on the slides and the presentation in the first half, and we'll respond to any questions you may have in the second half. If you do have a question, please send it to us via the Q&A option on Zoom. We've disabled chat to ensure that we can easily moderate questions coming in. But we haven't disabled the hands up function, but we won't be using it this time as we want to focus on presenting the content to ensure a good flow, and so we stick to time. If we do run out of time and we can't answer your question, we will endeavour to follow up with you offline. And last week we had 60 odd questions and we vowed to respond by the end of the week. So please do send any question and answer questions throughout the presentations and we'll pick them up later. So who am I? Well, my name is Mike Jones. I'm a GP. I work in London and I currently lead the challenge of caretaking a small practice over in Havering, which is in East London. I'm also the Deputy Medical Director for a GP partnership, and I'm a National Clinical Champion for Quality Improvement for the Royal College of GPs. I'm very proud tonight to introduce you to 2 guests. First up, we have Dr. Amelia Randall.
Hi everyone, I'm Amelia Randall. I am a GP from Somerset and the clinical lead for community settings of care for SWAG Cancer Alliance.
Super. And also with us tonight, we have Dr. Richard Roop.
Hi, I'm Dr. Richard Roop. I'm a GP in Hampshire and currently the Cancer Research UK Primary Care Advisor. I'm also a GP advisor for the Wessex Cancer Alliance and the Royal College of GPs.
Busy, busy, busy. So what's QOF and what's QI? Well, hopefully we all know what QOF is by now. And this year's QOF QI modules are of early diagnosis of cancer and also care of people with learning disabilities. We won't concentrate on the latter tonight. That was covered in a similar webinar this time last week, which is available on the college website. And to support these and previous QOF QI modules, NHS England and Improvement commissioned the RCGP in collaboration with NICE and Hull York Medical School and the Health Foundation, along with experts from a variety of other organisations, plus a huge range of learned colleagues, co-authors and contributors. We've been working since 2019 to produce the 10 QOF QI modules and its accompanying resources. Why is QI different to the old QOF? Well, if you've read the guidance, you may have found that practices are encouraged to understand where they have the potential to make improvements in quality. So then practices can design their own and implement their own bespoke QI plans, and that includes improvement targets to address these. I guess one of the other major differences is there are no deadlines given for any of these diagnostic activities. There's no deadlines for the plan and no deadlines for the network meetings. So it's over to GPs, busy GPs. But NHS England does say practices should be expected to be working on these throughout the year. For more information on this work, please visit the links on the screen. We can share slides after the webinar, so you have those and also all the other links we'll discuss. So that's rcgp.org.uk/QOF QI and also qiready.rcgp.org.uk. And lastly, if you're on Twitter, you can find us holding Twitter chats and promoting resources there by searching for hashtag QOF QI and @RCGP. So the two new QI modules for 2021, 2022 should include early cancer diagnosis and LD. So each of these areas has 2 indicators worth a total of 37 points per area. So that's 74 points in total. And these domains aim to provide support for practices, recognizing the areas of care which require improvement, and then taking steps to address this through development of your own plans and through sharing of learning across PCN networks. So the focus is really on practice engagement and participation in the QI activity, both in the practice and the PCN. Here's a slide straight from the guidance. The bits in yellow are possibly the most important, and they talk about demonstrating continuous quality improvement activity. So 27 points for that. And then also participating in network activity to regularly share and discuss learning. And that includes a minimum of 2 peer review meetings. So by peer review meetings, obviously nowadays that corresponds to PCN meetings. I won't talk to all the words on the screen, but it's been recommended that there is a minimum of 2 network meetings in which the quality improvement work should be discussed. And the timings are as suggested in the guidance, but also up there on the screen. In the ideal world, these would be face-to-face, but we are all muddling through and doing this virtually, or at least the majority of us are. Meeting number 1, hopefully, should be done relatively early, or that's as early as the quality improvement work has started, whereas meeting 2, ideally nearest the end of the QI process. Some practices or some PCNs, they do use the monthly meetings and have a standing item. Even if they don't use it every month, they will discuss quality improvement, and others will just use the 2 meetings. So the aim really is to share the best practice and offer supportive challenges to other PCN members' improvement goals. We don't expect the PCN CDs to necessarily be in charge of this. They absolutely should be nominating deputies or quality improvement leaders from one of the practices or some of the practices. And Richard, I think you have some good examples of how quality improvement work has taken flight in your PCN.
Yeah, so we engaged with this quite early, I guess, because of my interest, but also a couple of colleagues were also interested in the cancer arena. And I think it reflects really how important cancer is. And one of the things that I think probably isn't appreciated by a lot of professionals, both in primary and secondary care, is actually how huge the cancer agenda is. And one of the parameters that we think of as the NHS, what its role is for, is to try and prevent premature death. Because clearly we can't prevent death. It's waiting for all of us. But premature death is where we should be aiming our activities to try and get it reduced. So there's a slide just coming up, which I think beautifully describes how big the cancer agenda is. So if you look at premature death, which in the UK is defined as being under 75, and Joe, if we could have the next slide, you can see that cancer contributes 40% of under 75 deaths in England, and that's an average of 2017 through to 2019. And that is actually more than all cardiovascular, all respiratory, and all liver premature deaths combined. So the cancer agenda is huge. And in part, that is because of the amazing work that primary care has done in addressing cardiovascular morbidity and mortality. And on the next slide, we can see what's happened over the years. And if we go to the next slide, which will make an arrow appear, we can see that in 2011, cancer became the leading cause of all deaths, not just premature deaths, but all deaths. And again, that's not widely appreciated, but you can see how effectively cardiovascular undertook cancer. Encouragingly, cancer is coming down a little bit in terms of standardized mortality rate, but cardiovascular came down quicker, leaving cancer as the biggest cause of death for all ages. But in particular, from the previous slide, we saw it's by far and away the biggest cause of premature death. If we go to the next slide, this is actually interesting, the global picture, and you can see here how cancer has been increasing year on year over the past 2.5 decades, and interesting color chart just showing where those sites are. And you can see that lung cancer is the biggest contributor to deaths of the many different types of cancer. And the next slide, again, I just like the color graphic. This just shows the proportion of deaths for every different year of life. And you can see the big bulge of female cancers caused by breast cancer. And in men, you get that widening with prostate cancer as age goes on. And this gives the proportion of deaths at each age. Obviously, the death rates are far higher at the older ages. And on the next slide, we can then see how we've been doing in general practice, which is amazing. And no one's really blowing our trumpet, so I'll blow it for us. But on the left, you can see what's called the conversion rate, which is the proportion of our 2-week wait referrals that are proven to have cancer. And it's generally accepted that a lower percentage is better because it means we're referring at an appropriate level of risk. And the right-hand side is what's called the detection rate. And that's the proportion of cancers that are diagnosed through a rapid or 2-week pathway. And that's been going up year on year. This only goes as far as March 2020, because the data, once we get into COVID season, hasn't yet been fully analysed, but I suspect we may see a little reversal in that, a little notch. But from the data coming through, it suggests that our referral rates are back to pre-COVID levels, and in some cases actually higher. And the next slide, and I'll hand back.
Thanks, Richard. Yeah, cancer is huge. Where do we start? What should we focus on? What we don't want, what we fear is, because it's such a humongous topic and because it has such repercussions, is that anybody feels overwhelmed by either this webinar or by the potential magnitude of what the module sort of represents. And so we really want people to start thinking small, because there are thousands and thousands of GPs, practice managers, practice staff that are able to participate in this work. We don't expect any practice or any particular member of staff to make seismic changes. But I think what NHSEI are hoping that if each individual practice contributes a small brick in the building of this wall, then overall there will be some impressive changes. If not necessarily at the end of 12 months or year one, hopefully if some of the changes are changes for the better in terms of changing systems or processes in your practice, then we might find that there are some positive outcomes in year 2, year 3, going forward. So we all know that in terms of quality improvement, the embedding of changes and the sustainability of changes is probably the hardest part. So just going back to this slide, what should we focus on? Well, the module's been relatively explicit. It really wants to focus on improvements on two elements of cancer and how we can catch it early, how we can diagnose and therefore treat it early. Clearly, there's a human impact, but there's also an economic impact. And then there's also, I suppose, a professionally and a personal impact as well. So it wants us to focus on participation in screening. They are the three main, or the national cancer screening programs: breast, cervical, and bowel. It doesn't expect every practice to focus on all three of those screening programs. So please fear not, choose at least one. But the guidance does say that we must address both of these elements, not just screening, but also trying to streamline, trying to improve, trying to make better the referral practices. Okay, so these are patients you suspect of having cancer. And listed there, it does suggest probably the four lowest hanging fruit, including the use of clinicians and practice staff understanding, using, having to hand evidence-based guidelines. Also, and probably as part of understanding those guidelines, the professional development. So we really want practices to think about how can we all think the same? How can we all know where to look? How can we all communicate in the same language? And then there's the perennial safety netting, which we know that some practices do extremely well and some haven't quite got it right yet. And then finally, shortening diagnostic intervals. So when the patient first presents to when they are diagnosed. And that also really does vary quite significantly, not just nationwide, but also within a CCG or a PCN. So yeah, we need to focus on both of those. Each practice needs to focus on both. Okay, so this is another, what do we need to do? But we've tried to really simplify this. We tried to put it into 5 basic steps. And there is definitely a tension between trying to make it simple, but as soon as you make it simple, you then lose a lot of the finer details. So we really do want to say, there is, of course, the module to look at. I know it's 15 pages long, but equally there are a range of resources, which we'll put on one of the final slides to look at as well. So, and this is in the guidance. So number 1, step 1, evaluate the quality of your current care and identify areas for improvement. There are lots of different ways to do that. And we'll talk about this in a little bit more detail. Step 2, create an improvement plan and really try to emphasize or try to focus on clear aims. How are you going to reach your aims? You need to measure, and how you, and in order to measure whether your changes have been an improvement, that needs to be quite defined in advance. And then of course, between your practice or your PCN, you need to consider the change ideas. So not only do you have the aims, the measures and the changes, but we really would recommend using small cycles of change. You may have heard of PDSA cycles. And that way, once you implement a change, measure it, monitor it, and identify whether you need to continue that or discard that change before you move on to cycle 2 and so on. Step 3, make the plan happen. And that's sort of including the repeat cycle testing once more. Step 4, we talked a little bit about the PCNs, and definitely have one at the beginning, definitely have one near the end. And if you can have more, that would be excellent. And step 5, which is fill in the quality improvement monitoring template. Now, Joe, could I ask you just to flip back to slide 9? I thought it'd just be important, if you haven't already looked at the monitoring template, this is what you're going to need to fill in at the end of this quality improvement project, or the end of this year. Now, quality improvement is going on for at least the end of this year, at least another couple of years, and probably for much longer. So the monitoring templates will become very familiar. And I do think it's important to know in advance what you're going to, which areas you need to tackle, because you could possibly plan your quality improvement projects backwards if you just sort of see what you're going to be assessed on at the end. So like I say, each practice won't be individually scrutinized in terms of expected to make huge swathing changes, but on a national scale, we're hoping to see some improved outcomes. So if you flip back to slide 17. Okay, Amelia.
Thank you, Mike. So this is from the QOF guidance as well. This is sort of the cancer perspective on why we're looking to achieve early diagnosis of cancer, and hopefully it's familiar to you, the long-term plan ambition that by 2028 that we will increase the percentage of cancers diagnosed at stages 1 and 2 that is currently about 50% and raise that to 75%. It's also sort of noting the impact of COVID and the fact that there's a reduction in numbers of people attending primary care, and as a consequence there have been reduced referrals and actually a treatment gap. So we're missing a number of people that we would normally expect to have treated for cancer haven't come forward. So we're wondering where they are and how we can reach out and find them. So asking us all to retain a high index of suspicion and have a low threshold for considering cancer and referring, and do what we can to grow public confidence and encourage people to come in. So that's the sort of part from the QOF guidance to present this. And then I've just been asked to give a few views really on how it might work in practice for a cancer QI project. And I think it's really interesting because if you look at a typical QI project, you have a standard pathway that you have a look at, and you look for bottlenecks in the pathway and specific areas of improvement. And each patient generally follows exactly the same pathway if it's something like a preoperative hip pathway. But the thing about early diagnosis of cancer is there is no one pathway. Every single patient follows a completely different pathway. So it's about looking at all those different pathways and identifying learning themes and particular areas of most benefit. So there are various areas of data that you can use to look at. There's a fingertips, it's got a lot of national and local data. You may have participated in the National Cancer Diagnosis Audit, and then any other significant event analyses or practices that you've done previously. So there's lots of resources to look at. But what I'd like to encourage everybody to do is particularly review the pathways of patients that are that present with cancers at stage 3 and 4, and look at those pathways in particular detail. And ideally you might, depending on how many you have in the practice and who's involved, the absolute gold standard would be to review every single case of someone diagnosed at stage 3 and 4. But what I would say ideally is that everybody who's involved in diagnosing cancer does one pathway. So that would include your GPs, any nurse practitioners, anybody who sees people with non-specific presentations that could be cancer, to do one pathway themselves and then come together to discuss the findings. Can I have the next slide, please? And so this is sort of an illustration of what the opportunities are to diagnose cancer. So on the left-hand side of the screen, patient doesn't have cancer. On the right-hand side of the screen, they have succumbed and passed away as a consequence of the cancer. And in that process, first of all, you don't have cancer, but you've got risk factors and things that are going to make you more likely to develop cancer. And having awareness of what the risk factors are, including any genetic predisposition, can make you more likely to have more likely to consider it as a diagnosis if somebody presents. Then at some point, the cancer starts. There's been a mutation and the cells have started to go awry, and that's the earliest point that the cancer could possibly be diagnosed, because that's the first point at which it exists. But at that point, it's not causing any symptoms, nobody knows it's there. So the only way that it could be found is either by a screening test or as an incidental finding of tests done for other reasons. And one of the reasons that's been suggested for the treatment gap is that we've done many fewer routine investigations during COVID, and so there's been a reduction in the incidental findings. Which we're starting to sort of appreciate the impact that might be having. So at some point, these ball of cells get bigger and they start to cause early symptoms, and that's the first point at which you could pick the cancer up through a clinical assessment. In order to do that, it's got to either occur to the patient or the clinician that cancer is a possibility. If it's a patient that it occurs to, they've got to be confident enough and articulate enough and health literate enough to present themselves to a clinician and say what's going on and give all the relevant information that will help the clinician make a diagnosis. Then, if not diagnosed and if nobody picks it up, eventually the cancer will progress to stage 3 and 4. You'll have symptoms of advanced disease, weight loss, hepatomegaly, anorexia, and really the cancer diagnoses itself. I don't think there's any prizes for diagnosing a cancer with those advanced symptoms. So the challenge for us as primary care clinicians is to move progressively towards the left of this line. How can we learn from every single stage 3 and 4 cancer diagnosed? There's something to learn about how we could perhaps move that diagnosis earlier. And they're not all about the interaction with the patient and clinician, that specific consultation, but there's many, many factors influencing the information available to you and the decisions that you make during those consultations. Next slide, please. Oh, we've got a visitor. I'll just get rid of him. So this is a sort of representation of the sort of decision-making process, and this is based on sort of dual theory analysis. And basically, as in primary care, we've got so much information presented to us in a 10-minute consultation. We've got all of our education, we've got all of our past experience as doctors or clinicians, we've got the patient's record, all that information on the record. Then we've got what they come to us presenting with, the symptoms of the day, any knowledge we have of them personally previously, any results of the investigations. It's a huge amount of information for us to assimilate in 10 minutes, and practically not achievable. And so what we often do is we use a sort of heuristic approach, and we recognise sort of a constellation of symptoms and signs which makes us go, right, I don't need to go through the notes in a degree of detail. I know that this is a particular thing and that suggests a particular course of action. And so we reach an initial diagnosis, but that only works when we have this sort of system 2 method, which is going back, double checking, making sure that everything that we do going forward meets, fits with our hypothesis of what's going on. So we then look at the notes, we might organise some initial tests, we might examine, do further things, and making sure that although we've gone very quickly to initial diagnosis, actually it fits and there's nothing that hasn't fitted in that we need to think differently. And that's the way that we have evolved our assessment in primary care, and works incredibly well. But it doesn't work so well when people are under pressure. So we go to the next slide, please. And our system has been under pressure for many years, never more so than it is now. And what we see when we're under pressure is that there's a shortcutting, that you rely more and more on the system 1 and less on the system 2 checking backstops. And there's a huge number of factors that influence this: the primary care pressures, concerns about clinical risk. So you think, well, if cancer is a possibility, I'm just going to go straight on and do the test and not, further analyse it. They meet the 2 criteria, let's just send them off, without really sort of allowing that second process to come in. That negative feedback, personal fear of personal judgment from peers about misdiagnosis, and we don't really have a very good constructive feedback system of learning, I don't think, between primary and secondary care. Whether the loss of face-to-face consultation has an impact on this, very controversial. There's very good anecdotal examples of cases where people think that it was actually much quicker because you're able to identify risk factors remotely and then not need to wait for a face-to-face appointment. There are anecdotal cases of where things might have happened more smoothly had people been face-to-face. We don't know the answer to that, and that is a subject of research at the moment. But really, it's about maintaining curiosity and accepting that this is so complicated that it will never go perfectly. So nobody's expecting any clinician to do this diagnostic process perfectly. There will always be things that could have been done differently, and we sort of have a duty to our patients who've presented with advanced stage disease to learn from their experiences so that we can evolve and embed new practices going forward. Right, next slide, please. So this is just some sort of illustrations of the type of pathway analysis that you might do with an individual patient. And this, I think, is somebody that I was imagining that might have presented with some vague symptoms. So they've developed some symptoms, and before they, the influencing of developed symptoms is all about risk factor management. And then at some point, the patient might become concerned about their symptoms and want to, and that's the factors that influence that are, their cultural influences, their education level, any sort of public health messaging that's out there. And so as soon as they become concerned about their symptoms, then the next step is that they would seek advice and book an appointment with a GP. And just to mention, really, I've broken this down into PCN specific learning and system learning, because I think it's really important that we have both elements of that. And so for the booking the appointment with the GP, for example, then there's a question of were they able to access an appointment in a timely way? What were the barriers to doing that? Patient factors, practice factors, but also what are the alternatives to GP? Do all these patients need to come through the pressured primary care services? What are there's lots of different initiatives, direct access breast clinics, so those sort of things that so learning that we can have to the influence, particularly from the Cancer Alliances, what to take this information and say, well, this would be a useful thing, because we've had the learning from the QI project, would be absolutely brilliant. So yeah, so as we go through, then, the patient's concerned about symptoms, they book an appointment, then the next thing is the clinician's got to be concerned about the symptoms. So were there any barriers to getting enough information to tick that, flip that switch to say, right, I'm concerned this is a cancer pathway, and, things like access to specialist advice, be a system learning point from that. And then there's the process of, once it's occurred to you that cancer is a possibility, the booking the test and getting the test results and all those sort of practice systems that are there. And next slide, please. And this is another one that I just thought I would do to illustrate a sort of a screening importance one. So it's similar, the second half of the pathway is exactly the same, but this is somebody I was sort of envisaging, a cervical cancer patient who hasn't had, maybe had an abnormal smear test and then just didn't turn up to follow up for whatever reason, and then presents with cervical cancer, which of course, because it's a completely preventable disease, that is, a real area for trying to improve things, if as we know, it does happen for so many system, cultural, and environmental factors. So looking back to that and not thinking, oh well, what could we have done, the patient just didn't turn up for their screening test, but why didn't they turn up, what could we have done to make those routes of access more accessible. Yeah, so they're the sort of, that's just really to illustrate what you might do when looking at the pathways. I would imagine that this would be initially a review of the notes. There would be some situations probably where you could discuss this with patients, whenever I've been involved in a cancer diagnosis, I do try to speak to the patients about it. It's not easy, but really important to air any concerns they might have had about the route leading up to their diagnosis, and at least listen to any concerns they had about how it's handled, because if you don't, then it's going to be a barrier to you looking after them through their cancer journey. So getting their views, getting views of any relatives can also contribute to this, and really valuable source of information. So and next slide.
Amelia, that's just to go back to that slide. So that's, did you create this just from experience through looking at just through previous examples of where things have gone wrong, or was this a one or two cases that were audited in a practice or a PCN?
So these aren't specific cases, but they're based on my knowledge of a large number of analyses. So they're sort of illustrative of a fairly typical case, I think.
So practices could perhaps use those as examples or as ideas to sort of take away the peg pretty much from here.
Yeah, absolutely. Yeah, and there'll be different learning points for every patient, but
Okay. Thanks.
Brilliant. So yes, and this is just sort of about who you can get involved. I mean, I'm really keen in my role from the Cancer Alliance that we use these. I mean, this is just a huge amount of information, patient experience and primary care experience information, that if we can collate this and embed it in the system, I don't know how familiar people are with Cancer Alliances, but the Cancer Alliances are this sort of broad stakeholder organisation that bring together in a network anybody who's involved in looking after patients with cancer. We have a budget of funding and are able to fund new projects to help achieve the long-term plan objectives. So, and there's a varying degree to which Cancer Alliances are engaged with primary care. Hopefully that is improving as time goes by. It'd be really interesting to know from the audience whether they know their Cancer Alliance primary care lead and whether they've had any contact with them. But there's a real opportunity to feed this in and actually get tangible change of a system. So it's not just about local practice changes, it's about how we can evolve as a system to support these patients to come through. Certainly in my PCN, I set up a PCN Cancer Leads Network, which I'm sort of describing as a community of practice. And so attending those networks and discussing these cases represents a multidisciplinary shared discussion. So you don't need to do that only with your PCN, but you can have another broader discussion across the whole of SWAG. And we've mentioned patients and carers, who, there's hugely valuable insight that they will have into their experiences, which often, things that we hadn't really anticipated. Brilliant. I think is that my last slide?
Yep, that's right. Thank you. Richard, are you happy to speak to this?
Yeah, so I think having heard Amelia's great presentation, we might all just start to feel a little bit overwhelmed. But I think one of the things that's really important is that small changes can actually have a big impact. So one of the nuances that's changed that you may have picked up is we've moved from significant events to learning events, because significant events has a rather negative nuance, and it means that we messed up or maybe delayed something and contributed to a poorer outcome. But actually learning events can sometimes be positive. So why did a patient's referral pathway go so well? What was it that pricks the clinician's sort of go refer button? And what we can do through this QI activity is actually look at what small change could we make that will make a difference. And I'm sure we can all remember back to our first application to medical schools, and in our personal statement, we probably all put number one, we want to make a difference. And through this QI cycle, I think we really can make a difference. So we had an example in our practice, and it was on my watch, where I did a 2-week wait referral and got everything in place, but actually forgot to task the administrative team to actually enact this referral that was sitting on the system. Fortunately, I had mentioned to the patient, if you haven't heard from the 2-week clinic within a week or so, do get back to us. Fortunately, she did, and we were able to resurrect the referral and get it accelerated. But it just gave us the insight that actually safety netting is vital, and we could do it in a more constructive manner than just saying, if you haven't heard from the clinic, get in touch with us, because there might have been someone who was less articulate, less forward in coming forward, and may have been sitting languishing for weeks or possibly even months without us realizing that the referral hadn't gone through because it was still on the computer but hadn't had the green button pressed by my fantastic administrative colleague. So the patient kindly bailed me out of a hole that would otherwise have been a bit awkward and could have affected the patient outcome. So just a small vignette of how a small change can make a real difference. One of the things we're also very keen to do is to address inequalities. That little vignette, a very good example. There was a very articulate, well-educated, graduate level patient who took on board everything I said. And when she hadn't had the referral notification and the appointment notification, she actually contacted the surgery and made that initiative. So I'm very grateful for her. But if it had been someone where English hadn't been their first language, they may not have been at the same educational level, it might have ended up very differently. And it is thought that those sort of factors contribute to the inequalities we see in cancer outcomes. So we want to put in place something that will flatten that demographic gradient, which is still very much present, and is another fulfillment of the very wise words that came from a very eminent GP of the inverse care law, that those who need this are the people most likely to get cancer, coming from the most deprived backgrounds and who have the least level of advocacy. So, and thanks, Joe. So setting improvement goals, you'll probably all be familiar with the SMART goals, and I've actually heard a extension to them, which is the SMARTER with a squared sign at the end. So the SMART, if you can't remember them, they're specific, measurable, achievable, and relevant, and done in a time-limited fashion. But the E and the R, which again you may have come across, evaluate and review, which basically completes the PDSA cycle. But the final R, which I think is really important, is that it's rewarding. And it's rewarding not only for the patient, but actually for you, the clinician, and you, plural, the wider primary care team, because we are all looking for things that will add to our own personal resilience. We feel so downtrodden at the moment, but to actually realize that you're doing something positive that makes a difference and is good for you, the patient, and actually the NHS system as a whole. So it's better to have a small goal that is achievable rather than trying to save the planet, which probably isn't going to happen this year. So challenging but realistic, and it's a fantastic opportunity to build on those PCN relationships that are forming and to actually start working collaboratively and to provide a community of excellence that is looking to improve outcomes for our patients. Thanks, Joe. So implementing the plan, try and make it relevant for the practice team. one of the things that's really important as we go back to what might be receptionist triage, is there may be a case for enlightening them about some of the more important presenting signs of cancer. So blood in their wee, or maybe a lady with postmenopausal bleeding, or things like that, where the patient may not realize that it's urgent. Certainly in our practice, when patients have telephone approaches to the practice, one of the questions will be from the receptionist, is it urgent? And if the patient doesn't appreciate it's urgent, that can add an unnecessary delay to the patient pathway. But always good to be looking at continuous improvement cycles. So as Mike was saying earlier, the evaluate and review cycle is really important, and also important to close the audit cycle. And at that point, I'll pass back to Mike.
Thank you. I just wanted to add on to this particular slide. I know that even though it's September, even though it's 2021, some practices may yet have not actually started this work, and understandably, look at what's been going on simultaneously. But I did just want to highlight some of the resources that are available. They will be in the one of the final slides, and that's on the college website, RCGP. There are a variety of case studies there. So like I say, you need to sort of do some work related to screening, and there are case studies related to bowel screening. So one of the SMART aims there is to increase the uptake of bowel screening by 5% over the next 12 months. And there's a full worked case study example from start to finish, including the sustainability, the embedding, how the team went about it. Similarly, there's one for cervical cancer, increasing cervical cancer smears by 8% over the next 10 months. And that's just in order to reach their own local target. And then there's also a case study relating to early diagnosis of cancer, NCDA, and that has two prongs, and that's reducing the diagnostic interval from when the patient first sees the GP, which was 40 days, to when the patient gets diagnosed. So they're trying to reduce it to 30 days over the next year. The other one was trying to reduce the number of average consultations it takes to get a patient diagnosed, to get a patient referred. So there are just some other case studies which I really urge you to go and look at. You don't have to copy them. They are indeed there off the peg should you wish to get some ideas. And I can't not sort of champion Cancer Research UK as well, who also have a wealth of brilliant resources, as do Macmillan, and they include case studies specifically related to this QOF QI cancer work as well. So there is tons out there. If we haven't given you enough tasters in this session, do just have a quick flick over. If we go to the next slide. Thank you. Oh, this is some fantastic examples from Richard's practice and his PCN.
Yeah, so if you're looking for inspiration and have absolutely no time, you're very welcome to completely plagiarize this. So this basically is our flowchart that stemmed from the case vignette that I just gave you about the lady who we referred on a 2-week wait pathway and didn't actually click the go button. So since that happened over a year ago, we've now got the Arden's safety netting templates, which we're now using. So that really couldn't happen now because we're actually using that template actively, and the administrator would have picked me up probably within 48 hours if the referral hadn't been identified. So you're very welcome to plagiarize this and use this sort of off-the-shelf, off-the-peg program. And if we then look at the next slide, again, you can see an example worked out there. And again, very welcome to pick up the slide deck and just use this as a rollout of one option for the QI program.
Thanks, Richard. Yes, I appreciate that some of these slides aren't especially clear in this presentation here, but you, like we say, you are able to, everybody will get a copy of the slides sent to them after. So there are some other questions that we've actually touched upon. So hopefully, Joe Kirby, do you have any suggestions or ways of picking up patients that you've completed 2-week wait referral forms but not sent? And hopefully that's covered in Richard's 2 slides there. indeed, there are plenty of resources here. We've talked about the college. We talked about, there's 2 college ones there. Macmillan have got a toolkit, which you don't have to obviously complete the entire toolkit, but they have lots of mini sites and subdivisions with QI related resources. And similarly, Cancer Research UK. And don't forget, there are other sites like Joe's Cervical Cancer Trust and See the Signs. We mustn't forget to mention those as well. Then there's the cancer maps, which are a brilliant creation, which help you to identify via constellations of symptoms which tests you should consider doing. So I haven't put it on there. I will add it to the slides at the end, but cancer maps are another brilliant resource. So just going to our penultimate slide, just to summarize and say, well, hopefully we have covered a refresher of what QOF QI is. We talked about the dry contractual elements, which you will all have at home, but there is a link, I think on one of the early slides we popped in there about how to look at the contract should you've forgotten. Hopefully we've extolled the importance of cancer and given some examples, some tasters with how to diagnose and how to progress with actually determining which aims to decide upon. We haven't gone into lots of details about measurement today, aims, measures, changes, but they are crucial. And I would certainly recommend, if you haven't already got a grasp about what to measure or how to measure, do go back to one of our earlier webinars, the How to Do a QI project about 3 weeks ago, because even though Public Health England's fingertips provides us with some rich data, or your audit provides you with rich data, that data only gets updated irregularly, once a year or so. So you need to think about measuring the effects of your changes in an easy fashion, something that you can do by running a quick search, or that the administrator can do, a manager can do, or even a GP can do. So hopefully the resources are there for you, and we have about 12 minutes left. I can see we have 6 questions in the Q&A section already. So if it's okay with Amelia and Richard, I might pose a couple of these to you. There's a few, so a few of the questions relate directly to cancer alliances. Admittedly, some people have not heard it, some people have heard of them, but are unable to find the local cancer alliance. Amelia or Richard, but Amelia, could you just remind us how to best go about finding one's local alliance?
Well, so it's a very good question, and I think I don't know if I were able to access a list of the early diagnosis leads for cancer alliances. I wonder if we could include this with the recording, because there'll be a list of contacts basically, and I expect they'll all be delighted to be linked with this. But most alliances now have got a specific early diagnosis or primary care lead. There are a variety of different brandings of them, but they're usually sort of GPs or primary care clinicians that are concerned with that. So I'll get a list of them, and that will be the main contact. So you've got the primary care, the Cancer Alliance primary care leads, and then you've also got the CR UK facilitators. So Cancer Research fund some GP facilitator roles as well that work very closely with the Cancer Alliance. So that would also be another resource, and they're basically, their role is to reach into practices and support them to do quality improvement type work. And they used to be sort of focused on sort of advising how to do the work, and we're trying to evolve them more into actually doing the work, because it was a bit like having somebody visit your practice and tell you all the things that you would be doing if you had the time to do them.
Exactly.
So, yeah.
If you've got time to do it. So we absolutely, on it, we cannot deny, we totally appreciate just how swamped everybody is right now. But I think hopefully it's come through from Amelia and Richard that in terms of the smarter goals or the smarter aims, there is definitely a reward, or there should be a reward for this. So different to the old days of QOF, practices are now incentivized to come up with their own with their own goals, what's important to their personal practice population, and really spend some time doing this. Richard, anything to add in terms of cancer alliances before we move on?
I mean, just following from what you're saying there, one of the rewards if we're diagnosing cancer earlier is actually ultimately you will reduce consultation numbers, because the patient won't be coming back again and again. So if you make the right referral at the right time, it actually saves consultations, as well as enabling hopefully an earlier diagnosis. And we know that an earlier diagnosis has better outcomes. But actually, for the win-win-win, the third win is that it actually costs the NHS system less to treat an earlier cancer than it costs to treat a later cancer. So it really is a win-win-win if we can achieve it.
Yeah, I agree. There is one thing I think I missed actually along the way, was that, Richard, we know that you've done some great work on safety netting, but I think one of the other strands of the other strand for this cancer QI QOF was the screening element. And I wondered whether either via your own work or through work you've seen elsewhere, just how will you reduce health inequalities, and what has been done locally with you to try to reach those hard to reach people?
Yeah, so when I took on one of the cancer roles, so for 6 years, I was the Royal College of GP's clinical champion for cancer. And I felt as I went into that role that I better actually practice what I preach. So we actually addressed bowel cancer screening, and we essentially wrote a letter to every patient who had defaulted on taking up their bowel cancer screening invitation. So we did this mini little project where we sent out letters to about 200 patients. And interestingly, they were much more represented from the lower demographic end of our practice population, because again, we see the inverse care law, that it's the more articulate who take up the offer of screening, and they actually have a lower incidence of bowel cancer. And those who have a higher incidence of bowel cancer are less likely to take up screening. Anyway, we sent out these 200 letters. We got 30 patients who, as a result of that letter, wanted to do their bowel screening, and then we enabled them to get another kit. And of those 30, one had an early bowel cancer. So our strapline in that situation was 200 stamps to save a life. And a really easy project to do, and it made a difference for that one patient, huge difference. And for us, it gave us that warm glow that actually doing something helpful. We completed the review and evaluate, and it proved to be a really helpful thing to do. So now that is embedded within our day-to-day practice, and we can actually add to the slide deck an example letter of what we send to our patients.
Brilliant. Yeah.
Can I say something about inequalities?
Please do.
So I'm leading a local vaccination service as well as my Cancer Alliance role, and I think that has given us a huge amount of insight into inequalities and what drives them. And particularly the people that who've decided not to have a vaccine. The reason that they've decided not to have a vaccine fundamentally is because they don't trust the NHS, and they don't feel that the NHS is acting in their interests. And I think we really need to understand why that is, so that we can look after them better. And those that are choosing not to have a vaccine are probably people that are also choosing not to have screening tests and choosing not to present to their GP when they've got symptoms that are concerning. So there's a real opportunity to learn from these people. I see this sort of emerging frustration, because it's really frustrating when people don't take your advice. We're a caring profession. We want to look after people. When people choose not to follow our advice, and it is frustrating. But I think we really need to make efforts to try and step out of that and understand, see the world through the eyes of people who don't see the NHS as their trusted caring resource that we would like them to, and understand why that is.
Thank you. I was just going to read out a couple of the comments so far. So forgive me, Margaret Riley from Wigan says, in the Wigan area for St Michael's smears, we now have Saturday and Sunday appointments to accommodate in particular those patients working Monday to Friday. This is through our GP Alliance out of hours service, and it's proving popular. Now that does sound ideal.
Yeah. And
Yeah.
interestingly, we've done that locally, hugely popular, and it ticks your extended hours access as well. So it's a win-win-win.
Yeah, no, I agree. I just wanted to thank Pawan Randev as well for just, he's just published, he said, safety netting resource, cancerresearchuk.org, suspected cancer referral best practice. So I suppose that would go hand in hand with Richard's work. Like I said, CRUK just produced some brilliant resources. And we could even add that to our list if you like, for others to review. I think we only have 4 minutes to go, so I think it's time probably to bring Q&A to a close. So I want to say thank you to all the audience for participating, and thanks to Joe also, who's been answering questions frantically in the background. We'll look at collating any unanswered questions, and we will send the responses out to you, to everybody. And it wouldn't be a proper webinar if I didn't ask you to complete the short evaluation questionnaire that will come in your inbox very shortly, just to let us know what you thought of the webinar and how we can improve. And also to plug our other outputs. So they include, and I know there's been a couple of questions about this, the preceding 3 videos, plus this one, they will be available on the RCGP YouTube very shortly. There were also podcasts on the cancer and the learning disabilities modules. They are no longer than 12 minutes, I think, so they are bite-sized and available wherever you download your podcasts. If you haven't got 60 minutes to rewatch this, tell your friends. And there are plenty more case studies, there are top tips, there is PCN guidance, and a host of other resources that have been created especially to support practices for this work, and they're on the RCGP QOF QI webpage. And there's also QI Ready, which is a compendium of quality improvement tools, techniques, and resources. Amelia and Richard, it's not the first time I said it, but I'm going to say it again. Thank you so much. You've been really helpful, really amazing, and hopefully everybody else feels the same as me. And thank you to the audience for participating today. Good day.
Bye,
Thanks, everyone.
Thanks so much.